Exploring Women's Sexuality, presented by the program in Vulvar Health. Sexual pain disorders, such as vulvodynia, are remarkable and unique conditions that affect a woman's sense of health, sexual capacity, and daily comfort. This educational video is designed to provide a current and thoughtful framework to understand women's sexuality, with its complexities, beauties, challenges, and pleasures. Chapter 1: Defining Women's Sexuality. Sexual expression is a normal part of a healthy woman's life. Just like mental and physical health, sexuality grows and changes throughout a lifetime. Although many women recognize that sexual expression is healthy, some women feel confused about their sexuality, often wondering about what is normal. Since most of our culture's understanding about sexual expression comes from old models and beliefs that are heavily influenced by mass media, cultural expectations, and family and social upbringing, it is no wonder that many healthy women struggle to understand their own sexuality. Research in sexuality is still in its infancy, especially in the field of women's health. Several theories about human sexuality and sexual function have developed over the last century, but it wasn't until the 1950s and 60s that Masters and Johnson uniquely studied the dynamics of sexual expression. As pioneers in this field, Masters and Johnson developed a simple model of sexual response for both men and women. The sexual response is the way a man and a woman responds to sexual cues. The model shown here was developed by Masters and Johnson after observing hundreds of couples in their laboratory. In this model, the sexual response always begins with desire. We think of desire as a sexual hunger or lustiness, which usually drives a person to be sexual and to seek sexual satisfaction. As the model continues, desire then leads to arousal. Arousal is how both the mind and body respond to sexual cues. Women may notice this as vaginal wetness or genital engorgement. Men notice this as erection. Continuing along this model, we notice that arousal may then lead to orgasm, which is sometimes called climax. After orgasm is the resolution phase, where there is a reduction in sexual energy. This finishes the response until the next time a man or a woman is enticed by a sexual cue. As you can see, Masters and Johnson described a very linear process for sexual response. First there must be desire, and then arousal, and then orgasm and resolution. Although this model was simplistic, it was the first attempt at scientifically describing the sexual response. As research in the field of sexuality progressed, new ideas of how men and women differ sexually were considered. Researchers and clinicians in the field of women's sexuality began to wonder if the Masters and Johnson's model truly reflected how most women experience sexuality, especially those women in monogamous long-term love relationships. In the late 1990s, a new model for sexual responsiveness was introduced by a leading researcher in female sexuality. Dr. Rosemary Basson from Vancouver, British Columbia, offered an alternative model to Masters and Johnson's. Dr. Basson teaches the importance of emotional intimacy as the foundation for sexual engagement for women, particularly for women in committed relationships. When intimacy is present, women may find that they are more receptive to being sexually engaged. In this setting, they may find that their bodies respond to sexual cues even if they don't feel sexually driven by lust or desire. In the presence of emotional intimacy, a woman may be open and willing to be sexual even if she doesn't feel lusty. Dr. Basson defines this as sexual neutrality. In order to become sexually responsive, a woman needs to start from a place of sexual neutrality. This allows her body and mind to respond to sexual cues, whether they are cues from a partner, from thoughts, or from visual or auditory stimuli. Basson suggests that emotional intimacy fuels a sexual encounter as opposed to spontaneous desire. Dr. Basson suggests that in the presence of emotional closeness and sexual neutrality, women may be open to sexual stimuli and have a willingness to continue to be sexual. Some women do have feelings of lustiness and desire, although many normal women do not, particularly women in long-term committed relationships. Sexually neutral women who feel emotionally connected to their partner may find that their bodies respond to sexual stimuli. When this happens, women then experience sexual arousal and may notice genital changes that are generally perceived as pleasurable. Women describe their genital sensations during arousal in a variety of ways, such as warmth, tingling, wetness, or vibrations. They may also notice feelings of emotional connection and closeness with their partner. This may trigger and continually fuel arousal and desire. In some circumstances, this can culminate in orgasm. In Basson's model, these physical and emotional experiences can continue to validate positive feelings about the sexual encounter. This then enhances a sense of emotional intimacy, allowing her to be receptive and willing to begin a sexual exchange in the future. Sexual desire, according to Dr. Basson, is a responsive desire. This is physical, emotional, and sexual response that creates a willingness to continue to engage in sexual activities. This concept challenges the old idea that spontaneous desire drives every sexual encounter. Chapter 2, Sexual Pain and Sexuality. Even though Dr. Basson's model of sexual response proposes a progressive and thoughtful approach to women's sexuality, there are potential vulnerabilities to this model. For instance, there are several factors that may compromise a woman's ability to be neutral and sexually responsive, such as stress, fatigue, and partner relationships. Sexual pain is another important example, since pain interferes with the woman's ability to connect and feel close with her partner. It may also compromise her ability to stay sexually neutral, since sexual touch usually leads to pain. Research supports that sexual concerns are common for women of all ages. In one study of 3,500 women, 43% of those surveyed expressed concerns about their sexuality, and 7% of all women complained specifically of sexual pain. We understand that pain has a unique impact on a woman's sexuality and intimacy. Supporting a woman's sexual expression throughout her evaluation and treatment is vital to restore her sexual function in a meaningful way.
Women with sexual pain have described feeling angry, frightened, sad, hopeless, isolated, embarrassed, and overwhelmed. They tend to worry about their partner's sexual and emotional needs too. Concerns about the impact of this pain on their intimacy and on their ability to have children can be difficult to manage, even in the most stable relationships. In addition, if a woman worries during a sexual encounter, this may lead to a type of monitoring or watching during intimate moments. Masters and Johnson call this spectatoring. During spectatoring, instead of being in the body and in the encounter, the woman ends up observing the encounter, which can feel very unsexy or anti-sexual. When a woman is not present in the encounter, her desire can be decreased, and the sensation of pain is often increased.
When a woman suffers from a sexual pain disorder, the Basson model of sexual response is greatly impacted. A woman with a sexual pain disorder often finds it difficult to maintain sexual neutrality. Her pain compromises her ability to become sexually engaged. Without neutrality, sexual stimuli may fail to lead to arousal and desire. Also, when a woman feels inhibited, frightened, or avoidant, arousal will be delayed, limited, or absent, making it even more difficult or impossible to experience responsive desire. And without responsive desire, she may be unwilling to pursue or to agree to the sexual encounter. Once desire and arousal are eclipsed, positive outcomes are compromised. This greatly endangers emotional intimacy and often results in a relationship that is lacking in both physical and emotional connection. Brain researchers have identified an area within the brain that serves as an interface between emotions and rational thoughts. Emotional impulses can overwhelm the brain's rational thoughts, which is why many people with pain struggle to interpret their body's sensations. We understand that patterns of thoughts and fears can actually heighten the pain experience. Women with sexual pain naturally adopt techniques to manage their discomfort. These may include focusing, distracting, avoiding, and ruminating about their symptoms. Unfortunately, all of these strategies actually increase pain, which is why these chronic conditions are distressing and draining. Pain uniquely impacts a woman's ability to be intimate. While many women in long-term monogamous relationships experience challenges related to desire and arousal, pain complicates those feelings even more for women with a sexual pain disorder. Couples managing sexual pain often need help in maintaining intimacy as they journey together on the road to recovery. Chapter 3, Treatment for Sexual Pain. The program Involve Our Health is dedicated to helping women find ways to reduce pain and to improve their sexual relationships. After careful assessment, our clinicians may suggest a treatment plan that may include medications, physical therapy, outpatient surgery, and psychosexual counseling. Many of these treatments are often combined as a multidisciplinary approach in the treating of the physical, emotional, and relational challenges that accompany sexual pain disorders. Since sexual pain disorders affect intimacy in unique and challenging ways, it is particularly important to address the psychosexual health of the woman and the couple. Several treatments have been used to address these issues, including supportive counseling, couples counseling, biofeedback, group support, and mindfulness practices. Each of these techniques offer support and skills for the couple struggling with the unique challenges of sexual pain and intimacy. Research and treatments for sexual pain disorders are suggesting that managing the psychological aspect of sexual pain disorders is as important as treating the organic causes of pain. One strategy has been shown to be particularly helpful to reduce the distress: mindfulness-based cognitive behavioral therapy in a group setting. As taught by Jon Kabat-Zinn, mindfulness offers strategies to specifically manage pain, worry, depression, and anxiety. Studies show that it is also effective for treating sexual pain disorders, and several researchers have had success using mindfulness techniques, relaxation, and group support for women with sexual pain. In sexual pain disorders, mindfulness encourages a woman to become more aware of her thoughts, feelings, and internal narratives about the pain. Acceptance of thoughts and feelings actually decreases pain perception. Mindfulness allows her to experience discomfort with less fearfulness and therefore less pain. Sexuality is a normal part of every woman's life. Living and managing sexual pain disorders can be challenging and frustrating since they impact so many parts of a woman's life. These disorders particularly affect a woman's love relationship and her sense of sexual well-being. Through a supportive treatment program that includes mindfulness training, she will learn skills to manage and cope with her pain as she engages in a treatment program that will lead her to a more satisfying and pain-free sexual life.